And all right, so today we're going to go over very quickly, but I'm going to go over the background of this group and what our goal is here. We're hopefully going to do a little vote on both the charter, which you should have received via email, and also on co-chairs for this year. And then we're going to talk about some content. We're going to go over a little analysis we did comparing popular plans with our value plan designs, talk about some things that came up after our group wrapped up last year that people seemed interested in talking about, and then talk about, how to move forward for the 2027 designs. So the work group is largely folks that were with us last year as well, but we have a couple of new additions. So I think instead of everyone going around and speaking, this time I think we'll just have the new folks just say a little bit about themselves, and then we'll have our co-chair candidates give a little spiel about themselves too, so you can know who you are voting for. I think I don't see two of our new people on yet, but I do see Karen Politz. So maybe Karen, if you want to introduce yourself, we're excited to have you.
Sorry. I'm used to Zoom, so I'm not used to the Google thing. Thanks very much. I'm happy to join everyone today. My name is Karen Politz, and I am retired, which probably makes me one of the happier people on this call. But I worked for about 40 years in the field of health policy, most recently at the Kaiser Family Foundation, which now goes by KFF. And I worked on private health insurance issues, and before that, I was at HHS, helping to stand up the agency that is now CSIO, where I got to know Johanna, among other people. So anyway, very happy to join you today.
Thank you for being here, Karen. Thanks so much. Okay, and I think, let's see, Jake is not going to be with us, so we'll wait till next week. And then Molly from WellPoint, I don't see either. So our co-chair candidates, our chairs from last year have graciously offered to put themselves up for co-chair again this year. So I think Emily's on the call. I don't think Evelyn is here yet, so maybe once she jumps on, we can give her a second to say hello. But we'll start with Emily, and then we'll move on. Hi, Emily.
Hello. So I'm Emily Hudson. I am a social worker and a social work case manager for our county locations at Chase Bruxton. I'm also a certified navigator with the Health Benefit Exchange and have been a navigator through about 9 open enrollments, I think 8. I've been with Chase Bruxton for 10 years. And then I also do private practice for therapy. And I have a very big passion for health insurance. I was previously a member of the MHBE Standing Advisory Committee, and I've also co-chaired this work group in the past, as well as co-chaired the abortion access education work group in the past as well.
Thanks, Emily. I still don't see Evelyn, but we do have Molly from WellPoint, a new carrier. So Molly, we're just, so you know, we're going around for the new people on the group and our co-chair candidates. So I'll inviting you to just say hi and just do a quick, sentence on who you are.
We need stuff.
Can you hear me? Are you able to hear me?
We're having a little trouble hearing you.
Someone's talking, but I'm not sure who.
We can hear you now. I think, Molly, you're a little faint, but we can hear you.
Okay. Yeah, my name is Molly O'Brien.
Molly, you're not muted, by the way. You might want to mute Molly.
834 enrollment.
I muted her. Oh, I thought she dropped for another call. I think she meant to. No, okay. So what do we want to do? I mean, I know that Carlene is aware of this.
Molly, it sounds like you might be on another call simultaneously.
If I'm not mistaken.
I think I'm gonna go ahead and mute you and we'll just move on. Okay. Alrighty. So I think with that we can go ahead and move on. And if Evelyn joins us, maybe she can give a little spiel, or she can send her on an email introducing herself. All right. So did anyone have any questions about the work group charter? I'll take that as a no. So I think we can go ahead and take a vote on the charter, and then for the co-chairs, after Evelyn has a chance to send around a little information about herself, then we can conduct a vote later on the co-chairs.
I move to approve the 2025 Value Plan Work Group Charter as presented.
Thanks, Emily. Does anyone want to second Emily's motion?
I second.
Thanks, Allison. Any opposed? All in favor?
Aye.
Okay, great. So the charter has been adopted. Thanks, everybody. And we'll be in touch about co-chairs later on. Okay. So next up, since most, if not all of you have worked with us before or been on this work group before, I'm gonna zoom through these context slides. They're mostly here in case you need a little refresher. Feel free to refer to the slides, and yeah, if there's something you want clarification on later on, please don't hesitate to contact me. We can set up a time to chat, but basically these slides go over MHBE's authority and scope, and what's important here to know is that we serve both Medicaid and the individual private market, and our authority in the private market includes setting plan certification standards every year for the plans sold on Maryland Health Connection. So value plans are a part of our plan certification standards process. And so that is specifically what we are focusing on in this group. It's within the individual market, within our plan certification standards. And yeah, here's our kind of our statutory purposes here. We have a number of affordability initiatives. So we've got the reinsurance program, we've got young adult subsidy, and then we've got the state-based subsidy, which is a new subsidy program, which will replace young adult subsidy, but in 2026 will include the young adult subsidy parameters within it. It's just a broader subsidy it's aiming to replace the expiration of the enhanced federal tax credits, which are expiring at the end of this year, and that was established through some legislation in this most recent state legislative session. And if you're interested in more on the subsidy program, you can check out our board materials from the last couple of meetings, and also, yeah, feel free to reach out if you have questions about that. And our reinsurance program keeps our premiums lower in Maryland relative to the nation overall. And then value plans specifically, again, most of you know this, but basically value plans aim to standardize the cost sharing across certain plans, and carriers have to offer a value plan at each of the bronze, silver, and gold medal levels. And within the standardized plans and determining the cost sharing, we are kind of governed by the actuarial value, so the measure of plan generosity. So anything we do, I think that I have this on this slide. Again, if you're not familiar with AV or actuarial value, basically it just means that usually if we increase the generosity, or I guess reduce the cost sharing for one service, then that means that the cost sharing for another service will have to go up. So that's just a simplified explanation of that. And our goals for the value plans are to improve access. I mean, we have these affordability initiatives, but once people have their plans, can they use the plan before they hit their deductible? That's why we have the pre-deductible coverage in our value plans. We try and prioritize copays versus coinsurance because copays are easier for people to financially plan for. And then we, to the extent that we can, try to promote health equity through our plan design, like we do with the diabetes coverage in these plans. And then the idea is that this is more transparent. It's easier for people to shop for plans because they can compare based on network and quality rather than on the minutia of the plan design. So for value plan history, again, many of you already know, we've had value plans for a while, but it was only in 2024 that we standardized all of the cost sharing. So in 2020, we had some guidelines, again, as part of our plan certification standards, that each carrier had to offer a value plan at each of the bronze, silver, and gold levels. But it was, instead of a specific deductible for each plan, there was a cap for the what the deductible could be. And certain services should be below a certain copay, but didn't, have to be a specific copay. So through the various work groups that I have laid out here on this slide, we came to standardize the value plans in 2024. And again, that includes some $0 diabetic services in all of the metal levels of the value plans. And since we put a lot of work into designing the value plans in 2024, in the years after that, we haven't had to make many changes to the cost sharing. We've made changes where we could, but mostly, since all that huge amount of work was done in 2024 to really make those plans the best that we could. Since then, we haven't had to do too much. But again, we want to revisit it every year and make sure we're doing what we can. So we have a little bit of data here on value plan enrollment. So you can see that in the first few years of the value plans before they were standardized, enrollment of value plans, which is in the blue, kind of was increasing a little bit each year. Then we saw a bit of a dip after we standardized the value plans, and we were initially, wondering about that. But in this most recent year, in 2025, we're seeing enrollment back up again a little bit. So that's helpful to know. And then here, it's not organized sequentially, but we have gold in the middle, which is a little weird, but you can see here the breakdown of, again, blue, the value plan enrollment, just broken down by metal level. All the takeaway here is basically that silver plans, the value plan was more popular in 2025 among silver plan enrollees than in the other metal levels. And so when we're talking about metal levels, it's helpful to know kind of how many people are enrolled in each metal level. So you can see the bulk of our enrollment is in gold, with almost 50% of MHC enrollees enrolled in a gold plan, and then about a quarter is in bronze, and then another quarter is in various silver plan variants. And again, I think everyone here knows about the cost sharing reductions in silver plans, but the bulk is in the most generous silver plan variant for the lowest income people. So the cost sharing is the most generous. And then as the silver variants are less generous, we have fewer enrollees, which makes sense because of the way our premiums work here. Sometimes, or by the time you get to eligibility for these lower generosity silver plans, you're better off in a different metal level in a non-silver plan. So this kind of all makes sense, but it gives you an idea. And so when we're designing the lower generosity silver plans, we don't want to see enrollment in those plans anyway. So they look like pretty ungenerous plans, but we want to make sure that people are not really enrolling in them anyway. So some more data here. We have value plan enrollment compared to non-value plan enrollment split up by age group. And it's pretty, you can see like the slope here from 2024 to 2025 is pretty much the same in most age group categories, except for the over 55 age group. People in value plans are enrolling at a little bit of a higher rate than in regular plans. And then in based on income, we have the breakdown by income here. The two kind of interesting things are that, yeah, value plan enrollment seems to be growing faster in the lowest income group here, under 138% of the FPL, federal poverty level, and then also in the over 400% FPL bucket. So these are all kind of interesting things to note. We don't really have information on why, but just as we're thinking about our value plans, these are the people enrolling. So overall, our plan for this group is to recommend standards for 2027 for the value plans. Again, we want to promote the affordability of commonly used services while balancing the actuarial value constraints, and then think about whether and how to make more changes to support health equity. And then I wanted in this meeting to visit a couple of topics that I heard people were interested in kind of after our group wrapped up last year. So we're going to talk a little bit about prescription drug costs and mental health costs, and whether, what's in our scope to address, and the other things MHBE is doing around those topics. So to kind of get into the meat here, in order to think about why people may enroll in something other than a value plan, we wanted to look at the we did a little analysis of the most popular plan in each meta level, and then compared the design of those plans to the design of the value plans, and then we shopped it around with a couple of stakeholder groups. So instead of doing the whole spiel for you all today, I'm going to tell you the takeaways from that analysis, and then we're going to look at one comparison that is particularly interesting and might have kind of have implications for what we do in this group, and then move on to discussion. So in general, we had feedback that the value plans are already pretty well designed, even if they're not the most highly enrolled. And yeah, so some of the ways that we could improve are in the plan names. Some of the kind of non-value plans are attractive to consumers because they call out something in the plan name, like a $0 deductible or a focus on copays. We heard this from a group of navigators and brokers that were kind enough to speak with us about this. And then relatedly, high deductibles scare off consumers, and it's hard to convey the value of of pre-deductible coverage in a plan when people are pretty much just looking at the number and assuming that they won't be able to get coverage until they pay that much. Premium, pretty straightforwardly, is a decision-making factor for people. And then sometimes there's legacy enrollment. So it might seem that a plan is very popular, but it could just be that it was popular when the cost sharing was lower, and then things changed, but they auto-renewed because they weren't aware the changes were coming. And then we got feedback that the drug deductible, separate drug deductible, is, even though it seems like it could be confusing to people, it's beneficial because it helps out consumers with expensive medications. And then lastly, like I mentioned, those lower generosity silver plans, even though we are kind of hoping that people are not enrolling in those plans. We are still seeing some people enroll in them. And so how can we, get people in different plans? So this is an example of the kind of what we were doing with this analysis. This is the gold plan. And this was really the only place where we could maybe see some room for a change in our value plan. So I'll just tell you what you're looking at here. So basically, yeah, this Blue Choice HMO Gold $1,750 deductible plan has the highest enrollment. With the enrollment line, you can see there's 35,000 people enrolled in that plan, most popular gold plan. And then our value plan is the second most popular. And it's interesting that although it has a higher deductible at $1,750, compared to the value plan, $1,000, that the enrollment is higher. It's a more popular plan. We would think that people would go for the lower deductible. And you can also see the premium is lower. It's the 7th cheapest premium compared to the value plan as the 11th cheapest. So I note here in the green that there's some $0 cost sharing for primary care and mental health. Otherwise, they're pretty comparable plans. So the question here is, are people drawn in by the free primary care and mental health, even though the deductible is higher? We had feedback from consumer assistance workers that this could be legacy enrollment. People are enrolled in this plan from when the deductible was lower, but it's worth considering whether maybe people do have a tolerance for a little bit of a higher deductible if the commonly used services are even cheaper. So we'll discuss that a little bit. We'll have another opportunity for discussion later on, but I think I'll just pause here for a second. I've been talking a lot, and I wonder if anyone has anything to add.
Becca, I have a question. Oh, I'm sorry. Let Stephanie go first.
Oh, thanks. I was just wondering if the brokers said whether the word value meant anything in particular to consumers. And my thought there is, I wonder if they're looking for a higher metal plan, but the word value is in there. I wonder if that makes it seem like it could be less good, like, like value meal. I don't know if that's, I'm just wondering if they said anything about the word value.
You're absolutely right, and they did, and that's something I had on a later discussion slide. So great point, and we can talk about that now. We were interested in exploring other names for these plans other than value, because we've been hearing that value might be giving people the wrong idea. So thanks for bringing that up. I guess Ken.
With all of the slides, is there any indication of usage? I know we've encountered in especially some of the healthcare, the non-cost healthcare visits where people are enrolling in the program, but they're not using the wellness pieces and the no-cost components of the individual plans. Is there any information we have to give us an indication of, has usage increased? Has it diminished? Is there certain areas where, or certain plans that the usage is higher?
That's a great question. I think that's something that we can look into. I wonder though, and this might be a question for Johanna, whether we can kind of drill down to the value plan specifically, or if we would have to kind of see, because we can tell kind of on a broader basis, how people are using their plans, because that's how we determine AV, like how often people use certain services. But I think we would have to do some other type of analysis to see with the value plan
Well,
specifically.
There's a
And
follow,
I can-
there's a follow-up to that.
Thanks, Joanna.
When you look at the higher enrollment, it's significantly higher in that silver plan. And the premium is higher. The idea is because they have more skin in the game, is there higher usage in that kind of plan? You know, when people are paying for it, they have a tendency to be a little more conscious about, okay, I want to get a return on my investment, so I'm gonna use it. I don't know.
I'll say a couple of things there. One, we did an analysis with Hilltop using all payer claims data several years ago, looking at our value plans, and this was before we launched the standard value plans. So the value plans had much looser parameters around what you could do to be a value plan. At that point, and this was again kind of early in the value plan evolution, we didn't see a significant difference in utilization between value plans and not value plans. We are in the process of working with Hilltop to do a more targeted refresh of that evaluation and specifically look at utilization of the free services for diabetic care that we've made $0 in the value plans and see if we see increased utilization in specifically for those services compared to non-value plans, and to whatever extent we're able to if we see any difference in outcomes, which is limited with what you can see in claims data, but we'll assess what we can find from the outcomes there. So that's in the early stages. We don't have results from that. And then in terms of whether people in higher metal level plans use more services, they definitely do on average. That's taken into account in rating. Brad or others on the call could probably speak to in more detail to that, but there's, you know, well established data that when people are in more generous plans, they use their health care more. And maybe I'll hand it off to Justin.
Thank you, Joanna. That's great. Yeah, it's just that sometimes it's that kind of thing where if I'm getting it for free, I'm getting it for free. I'm not all that concerned. I'll use it when I need it. But the whole idea of what we do is to keep people healthy. And if they're not using the free services because they don't have any investment in it, it might be a way to look at this and say, well, maybe there's a premium cost tolerance that we could put into some of these plans that increase it and maybe free up some dollars to go in other areas. I don't know. It's just an open question.
Mm-hmm.
Thanks, folks, and it's good to see you. I had a question really actually going back to the chart about the two gold plans, but I would just jump in maybe on that last point to say, I think there's a lot of research to suggest that as soon as you do start putting even little barriers, you really do see a reduction of needed care, along with perhaps not necessarily always needed care, but certainly you cause people to get less care than it would seem that they need. And so I'm a little, I guess, initially would be concerned about that sort of strategy. But back on the gold plan comparison, I guess one thing that I'm curious, just looking at this, because we seem to understand that premium does drive things so much that the fact that the cheaper premium plan has a lot more enrollment in and of itself is not super surprising to me. I guess I would be curious about the other plans not displayed here. I mean, the reason that, and I know there could be several reasons, but the extent to which cheaper plans 1 through 6, the reason that enrollment is gravitating to this more expensive plan rather than another one. And I don't know. I guess I'm just saying that in and of itself, I'm not sure how much we can infer that consumers really prefer the design of the one on the left versus the one on the right, given the preference on premium.
That makes a lot of sense. Yeah, you're right.
Yeah. And I would say, Justin, just in sort of like, why aren't plans 1 through 6 higher enrollment than plan number 7? I think, there may be carrier preference, network preference could be two of them. Also, the
Yep.
legacy enrollment issue that Becca mentioned, that Care First has been, with the exchange since the beginning, and we've had other carriers that have joined since who might be in those lower price cohorts, but don't have that auto renewing kind of
Right.
base of membership.
Thanks.
Nikki?
Thanks. I was just curious. It's great to hear about the evaluation that's being done for the value plan services. Do you have any timeline on when that will be completed and if it will be shared publicly?
I don't, we're so early in this process that I don't have any more details, but I think we definitely would like to share the analysis when it's ready. And I don't think it'll be done in time for this work group to use it for decision making, and it's decision making for 2027 plans, but when it's ready, we would be happy to share findings from it.
Okay, thanks. That's helpful. Yeah, I think we talked a little bit about it last year, but definitely just want to encourage, data-driven decision-making before we, like someone mentioned, any, $0, low-dollar cost sharing that we're putting on a different service takes dollars from other places. So we just want to make sure that these benefits, or what we're presuming as benefits, are certainly, quote, not to reuse the word, but benefiting folks and that they're actually using them. So thank you for initiating the evaluation.
Thanks, Nikki. Alex?
Good afternoon, everyone. And I second that comment. Agree that we're pleased to hear, an evaluation and progress on that component. And in a similar vein, I'm wondering if at a future work group meeting, we could do a deep dive into the impact of enhanced PTC expiring and the addition of the expanded state subsidy and how these value plans will stack up against non-value plans. Certainly affordability is going to be a really big issue next year. We expect enrollment losses as a result of that expiring EPTC, and luckily the state subsidy will help shore up some of those losses. But I do think it's important to think through how the value plans will compare to the non-value plans, and if we'll see movement towards some of the cheaper plans next year. And I don't think we'll have that data in time for the work group to wrap up, but anything we can do to assess the impact of those policy changes, I think would be great to help inform the decisions we make for the 2027 plans.
Yeah, that makes sense. And we can talk more about our subsidy program design next time, since many of you all may not have gotten those presentations at our board meetings. And yeah, I agree. It's helpful to think through the impact of that on what we might want to do with these plans. Karen.
Thanks. I wondered if there's been any discussion, or could there be any discussion about further reducing the number of non-value plans that insurers can offer. If we're talking 4 at each level, that means consumers need to compare 12 plans for each carrier, which I think is probably a lot for people apart from what you name the value plan. And this may be way outside the scope of this group, but I wondered if there is contemplation of any other policy changes to bring down the cost of health insurance plans, or bring down the cost sharing for people. This is totally beyond probably the scope, but I'm in Medicare, and this year, for the first year, the drug plans, the Medicare drug plans, have to count against the consumer's out-of-pocket limit the discount that the insurer gets through its PBM on each of the drugs. So it's a $2,000 out-of-pocket max. But if the insurer received a $500 discount in the cost of the drug, that gets applied to the out-of-pocket max, and that's a federal law now. So I didn't know if there are any other kinds of thoughts about ways that we could bring down the cost of plans or require carriers to just bring up their loss ratios. So thanks.
Yeah. Yeah, great point. About needing to bring down the cost of insurance. I do want to address your first question about the number of plans per metal level. In 2025, this year, we had a plan certification standard reducing the number of plans per metal level that insurers are allowed to offer to 3, and one of those must be the value plan. So currently, it's insurers can only do 3 per metal level, with the value plans being 1. So making a little progress on that. Yeah.
And on the bigger picture affordability question, I don't know that there's anything as direct as sort of like what you described for Medicare or something like specifically looking at MLRs. There was legislation to expand the authority of the Prescription Drug Affordability Board this past session in Maryland, and Stephanie, I know, could speak to that briefly. And then the state is negotiating the terms of the AHEAD model with CMS, and I am not up to speed on the latest in that process. I know there have been a lot of conversations, but I think that's kind of like big picture, at least was meant to encompass the state's strategy to improve health system affordability through many things, including improving population health and preventive care and creating a total cost growth target. But Stephanie, do you want to talk about PDAB briefly?
Sure. So the Maryland Prescription Drug Affordability Board already had the authority to set upper payment limits for high-cost drugs for state and local governments. But this past session, they also gained the authority to set upper payment limits for high-cost drugs for all Marylanders. That doesn't go into effect until we think sometime next year. And currently, the board is looking at 2 drugs for diabetes, Farxiga and Jardiance, and assessing affordability challenges to state and local governments for those 2 drugs. We're hopeful that they will make a determination about how to handle affordability for state and local government in the next couple of months. And then that should set them up to look at that for the broader Maryland population next year. So there's progress being made, and it's very exciting. But it might not have a lot of impact for plans for, in the very near future.
Thanks, Stephanie. All right. Any more comments before I move on? We have a little more content to get to, and then more questions for discussion. So I think I'll just move along now. And okay, so right on schedule. Yeah, so I wanted to revisit some topics that people were interested in after we wrapped up last year, and one of them was about prescription costs. And so thank you, Stephanie, for that that information on PDAB. So if anyone's interested in that or interested in commenting as a member of the public on what they're doing, feel free to check them out. And then we're going to talk more about kind of drug costs in the value plans on a later slide. But just in terms of what we're doing for affordability for these things, at least with generics, it is if the cost is lower than the value plan copay, then consumers, or for any plan really, if the cost is lower than the copay, then the consumer pays the lower amount. I also heard from someone after the last group that they wish we'd focus more on the cost of mental health care. And I also know that network or availability of providers, I guess more accurately, is a big issue. But what I can talk about here is, if you're not already aware of the Mental Health Parity and Addiction Equity Act, this piece of legislation requires that mental health benefits be just as generous as medical benefits. And so there are kind of different, there's like a special way of determining this. It doesn't mean necessarily that copays have to be equivalent, or the cost sharing has to be exactly equivalent. It has to meet this other kind of, they have a way of figuring it out. And so it worked out that some of our plans, the mental health cost sharing was not the same exactly as the primary care cost sharing. So we introduced a plan certification standard for 2026 that will ensure that not only does the mental health benefit equal, or not only is the mental health benefit kind of equal to the primary care benefit, the cost sharing is also the same in our plans on the exchange, and then also that they are we're encouraging carriers to use copay rather than co-insurance for those things. So we're kind of trying to simplify things for people there. And then lastly, we're always thinking about the diabetes care portion of this. And so, we've had the $0 copays for certain diabetes benefits in the value plan since 2020. And then in, again, 2024, we added a whole suite of services that are free. And then we added insulin as free insulin as a requirement in 2025. So just to get into how our value plans stack up with other states' standardized plan cost sharing, I kind of highlighted here, you can see that Maryland is really leading in many of the, across many of the states and the federal exchange for generic drug cost sharing for some of the metal levels. And then for the other ones, we're kind of on par, at least in the bronze plan. And then in these plans that we're hoping people are not in anyway, we're in line with what is typical, even if we're at the top of the range here. But basically the takeaway here is our value plan generic drug cost sharing is pretty good compared to other states. And I also have a comparison for the mental health office visit and outpatient visit cost sharing. So again, green means we're like the lowest across these states that I did the comparison for, and then blue means we're in line with what is normal. So so basically we're doing what we can. We're already doing pretty well is what the takeaway is here. And then just for kind of a review, these are all the things that are included in that $0 cost sharing for diabetes. And then the blue here, this is kind of more specific drugs and things. So you can look at that later if you want. So for this year, we wanted to talk about, just for clarity's sake, CGMs are not currently part of, continuous glucose monitors are not currently part of our value plan diabetes cost sharing requirement. So CGMs, if you don't know, it's a wearable device that allows for continuous monitoring of blood sugar rather than kind of testing, which is what a diabetic would do kind of ad hoc to determine their blood sugar. So these are helpful for people monitoring their blood glucose, whether they have type 1 or type 2 diabetes. They're definitely standard for type 1 diabetics, but the coverage of CGMs for type 2 diabetes has not been as consistent, even though it can be helpful for these people to manage their A1Cs as well, even if they're not insulin dependent. But these are expensive devices. Other entities are expanding access, though, for type 2 diabetics who are not insulin treated. So Medicare is now allowing type 2 diabetics to access CGMs, even if they don't use insulin. And then, for example, in the Colorado standard plans, they do have a $0 CGM requirement in their standard plans. And then we have looked into, we've asked our carriers, thank you to the carriers on the call for looking into this, that the the impact on actuarial value is pretty low. So that's good information to have since we're always thinking about balancing the AV. So currently, carriers kind of have a range of different policies for covering CGMs, or not for covering them. They're all covered in all the carriers, but the cost sharing varies. And so you can kind of read here later on if you're interested, but basically it seems to be that coverage differs based on whether the CGM is in the formulary or covered using the durable medical equipment benefit. So for Care First, there's one that is on the $0 share of their formulary, so all enrollees have access to that. Kaiser, it varies, but it's the durable medical equipment cost share. United has kind of a mixed approach. Some of it's formulary, some of it's DME, depending on like how the claim is submitted. And then for WellPoint, again, some of it's formulary, some of it's DME, I think. So so our thoughts are that perhaps we should add a free CGM to the requirements for the value plans, and then otherwise think about changing the name of the value plans, but then in general, kind of maintaining the designs from 2026 for 2027. And then we can think about whether we feel like that comparison for the gold plan is compelling, if we want to raise the deductible a little bit, if we want to do something else to that gold plan to make it more appealing or better for consumers. So with that, I'll open it up again. People have thoughts on the CGM question, on the gold plan question, alternatives to value plan names. I'll open the floor. Well, so I guess just to summarize what people were talking about before, it's sounding like maybe there isn't a compelling enough case to make a change to the gold plan. But if I'm wrong about that, I can allow people to speak up.
I think getting a little bit more information, like we had discussed before, about use could be helpful before we commit to changes. But I definitely think trying to come up with another name other than value plan is a priority.
Thanks, Emily.
Yeah, I certainly agree on alternatives for the name. I'm not sure that I have any good ones for you, but I think that's a good idea. And in terms of making changes to the gold plan itself, to be clear, I'm not necessarily opposed to that. I guess I'm just saying my initial look and the first time I saw that comparison is that it wasn't clear to me on its own that that sort of difference in enrollment was super indicative to me of consumer preference, but I'm sure there's more to be talked about here.
Thanks, Justin. Nikki, and then Steph.
So would the goal of changing the gold value plan to look more like the Care First gold plan is to increase enrollment? Is that the goal here?
Yeah, just to make sure that people are enrolling in the value plan, since we're designing them with priority of access to services. But it's a worthwhile question, because what part of the analysis that we did was kind of thinking about, well, sometimes the value plan is really filling a gap in the market, and perhaps by making more similar to the Care First plan, maybe that's duplicating something that's already there.
Right.
So that's definitely a point of discussion.
Yeah. Yeah, I guess that's kind of what I was hinting at, is if you're, just going to copy an existing plan in the market, I guess I'm not entirely seeing the value in that. And I think Johanna hinted at this, but that's our longest standing plan. We've been in the market since the start of the exchanges. And so, obviously we're biased, but consumers have different reasons for choosing a plan. And so I just want to make sure I understand the goal and kind of the catalyst behind some of the changes, and that just mentioned that, we might not always have the answers to consumer behavior, and that necessarily reflecting an existing plan that's already on the market may not be the best, decision. But this is a work group, so it should be a discussion.
And I would just add, so the purpose behind doing this analysis of comparing the value plans versus the most popular plans, as Becca kind of said, is not necessarily to say, well, we want the value plans to definitely be the most popular plans, because again, there may be circumstances where, like Becca said, there's a gap in the market and maybe the value plan is going to have a higher premium, and that's just going to mean it's not going to be the most popular plan, but it will offer that better cost sharing for the consumer. And we think that the market should have that option for people who want it, knowing that other people may just choose to shop purely for the cheapest premium. So that said, we still wanted to take a look at the comparison and say, we kind of went into this wanting still though to design a plan that's going to be appealing to consumers and is going to have cost sharing that meets their needs. And thus the comparison and the conversations with brokers and navigators to say, like, do you feel the value plan is doing that? When we look at this more popular plan, is there some reason that it's more popular that we weren't thinking about and missed when we were doing the value plan designs? And really across the board, we felt in doing the comparison ourselves and in the broker and navigator conversation that no, the value plans had been thoughtfully designed thanks to, the work group's input and all the thought that went into them. And we really didn't see something that was evident when we did a comparison that we thought, oh, that feature is something we should really consider for adopting for the value plan. And really the exception was looking at that gold plan and just thinking, we do try to minimize primary care and mental health and some of those other commonly used service copays. And we saw that, to our inspiration, the popular Care First plan did do that at the price of a higher deductible. And so we thought maybe, separate and apart from trying to chase whatever is making that plan more popular, perhaps that's a trade-off that the group would be interested in discussing, because that has been something that we've talked about, is reducing that primary care copay. But again, that plan exists in the market, so it's not necessarily to say the value plan needs to mimic it, but that was kind of the thinking that went into bringing this before the group.
Okay, that's helpful. Yeah, and I mean, as we continue to decrease the number of plan options, I think it's important to keep the little diversity in plan options that we still have left. But that's really helpful context. Thank you.
Thanks for that, Johanna and Nikki. Stephanie?
Thanks. It is interesting to me that the phrasing of value plan came up because, and I'm a focus group of one here, but when I was comparing the two plans, I did think, I wonder if there's something, and I've served on the value plan group, so clearly I knew the answer was no, but I wonder if there's something about the value plan that is hidden, because all these numbers, they look pretty similar in a lot of ways, but what's that value mean? And I just think we're in an environment where there's uncertainty for people about their health coverage, and also sometimes accidents or mistakes happen. People get bills that they weren't expecting. That happened to me recently. You know, a provider and the insurance company, there was just like a misfiling of the billing, which resulted in a really scary looking bill for me. So I think people are kind of sensitive to what if there's a healthcare cost that I'm not anticipating, and not knowing what the word value means maybe could be a little concerning for folks. But I'm wondering, for the other states that offer standardized benefit designs, what kind of language are they using for their comparison plans? And do they also have they looked and done this kind of analysis themselves, like comparing their standard benefit designs with the other plans, to see how their messaging has been working? Because maybe we could use some of what they've learned if that's the case.
Yeah, that's a great question. I don't know if they've done like the comparison, but I did try and find the kind of consumer facing names for the standard plans in other states, and a lot of them just use the phrase standard plan. But some of them, one state calls it the clear choice plan, which seems, oh yeah, thank you, Johanna. Johanna put in the chat some of the names that we found. So yeah, Maine calls them clear choice plans. Washington is Cascade Select. Connecticut is choice plans. And then the federal exchange uses the name easy pricing. So those are some ideas. And then we also plan to, every couple of years, we do user testing of the plan shopping experience. Our marketing team works with a contractor to do that. So this time we're gonna ask them to test some different names. So hopefully we'll get somewhere with that. Emily has a hand raised.
Yeah. Yeah, I think one of the things too to consider is, because a lot of those like APTCs and things are going away, and some of those reductions in cost, I think that also will help to differentiate this plan a little bit more, especially if we do things that make it a little less expensive monthly or to use the plan. If we're able to play with some of those numbers so that people can budget better in uncertain times and know that, you know, what their monthly expenses are, what their typical expenses are when utilizing a plan, could be helpful. Because I think that $0 for copays is really awesome, but if you have certain cost sharing and APTCs, that Gold 1750 plan can sometimes be less money monthly than the value plan. Plus, they have those zero copays for care at your GP, versus the $10 copay that costs a little bit more a month if you don't have some of those cost reductions, which will be gone soon.
Yeah, that makes sense. Oh, thank you, Justin. Justin has added in the chat more names. Minnesota is Easy Compare, and New Mexico uses Clear Cost. Kathleen has a hand up.
Yeah, I was curious about the second point on the slide here, talking about the continuous glucose meters. I think it's a really interesting idea. Would that be something that would like have to be factored into the actuarial value of the plan, where we would have to like play with the numbers in other places in order to make it even out?
Yes, and I had on a previous slide, I should have put it on this slide too, that some of the carriers have estimated how much of an impact it would have on the actuarial value. One of them, it wouldn't have an impact because there's a CGM already available, but the other one's estimated less than 0.1% impact. So it could impact it could put us over the limit. We'd have to look more at basically, since we don't have the 2027 actuarial value calculator yet, that'll come out later in the fall. And the feds released that. That's a federal product. So we won't know how much room we have to. So basically what happens is when they release that, then we know what our maximum out of pocket amounts can be. And so if we need to increase the maximum out of pocket amount a little bit in order to accommodate that last 0.1%, if we need to, we can, but we won't really know until then. But yeah, at that point, it would probably be helpful to get kind of a more specific estimate from carriers on how much of an AV impact it would have. But so far, it's seeming small.
Okay, great. Thank you.
Yeah. There's some good conversation in the chat here about plan names. DC calls them essential plans, and then Kakia says that we could call them complete plans. But Nikki makes a point that all plans cover the 10 essential health benefits, so we couldn't necessarily say that some plans are more complete than others, I think is what she means. Okay. So another thing I'm interested about, that I'm interested in hearing more from carriers about is kind of the benefit structure for CGMs and how patients normally get their CGMs. I know the formulary versus durable medical equipment distinction is there, but I'm not clear necessarily on how people usually get their CGMs. I guess through the pharmacy, but again, I'm not really sure. So it would be helpful just in terms of being able to kind of phrase the potential new requirement to understand more how people get their CGMs so that we can say, whether it's formulary or durable medical equipment, one CGM should be available for 0% or $0, depending on which kind of avenue it's being covered through. So anyway, don't know if people have thoughts on that.
I think it could be possible to raise the deductible a little bit since we've seen that people have gone more into one that has a higher deductible.
Yep, that's a possibility. Any more thoughts on any of these questions? All right, so sounds like, yeah, we'll bring a little more information next time. But oh yeah, I was going to talk about next steps. We technically have public comment, so if anyone wants to speak up about anything, anything that you think we're missing, we should be discussing, things you'd like to see next time, anything. All right, well, feel free to email me later too. You don't want to speak up now. So next steps, like I said, we'll share some follow-ups from this meeting. We got through all the content, so we don't have to continue that next time. But I was thinking we would present you with the first round of draft designs at that time as well. How does that feel to people?
Sounds good.
Great. Thank you. Okay, so the next meeting is in 2 weeks on September 9th at the same time. Okay, and I'll send around the slides after and post them on the website. Okay, if there's nothing else, I think we can wrap up for today. Thanks for an efficient meeting, everyone. See you all next time.
Thanks, Becca.
All right, thank you.